Testosterone is having a moment in the women's health world. Everywhere you turn, someone's talking about how it boosted their energy, brought back their libido, helped their muscle mass, or gave them their confidence back. And honestly, I love that women are finally waking up to the fact that testosterone is not just a male hormone. We make it too in great abundance, and when it's optimized, it can be life-changing. But here's the twist no one really wants to talk about. Testosterone replacement for women is still the Wild West. The FDA has never, which is ridiculous, approved a testosterone medication specifically for women. Yet, we can get it through compounding pharmacies. And we have an entire buffet of delivery systems, some great and some very questionable. We're seeing pellet clinics popping up everywhere. Pellets are definitely not my first go-to for women. In fact, I see more problems with pellets than almost any other delivery form. And we'll be getting into the whole pellet thing in today's episode. Now, while testosterone can be incredibly beneficial, it comes with some real, very unglamorous side effects that women are dealing with every single day in clinical practice. Side effects that no one warned them about, side effects that were totally avoidable, and side effects that can be downright scary if you don't understand what's causing them. Now, before we dive into the nitty-gritty, let me tell you what pushed me to record this episode in the first place. Last Friday, I was talking with a good friend of mine in person, and she is in midlife. She's my age, 49. She is on her own hormone journey and getting prescription testosterone replacement therapy from her doctor. And she shared that since starting testosterone, she's noticed that during sex, her vulva and labia and clitoris become so engorged that she feels embarrassed by how dramatic the change is. And it's something that her partner has noticed. Now, thankfully, her partner is fantastic and has been very clear that it's not a problem, but obviously concerning for her. She had no idea this could ever happen, which is why she talked to me about it. And I told her after the conversation, I said, you know what? I need to do a podcast episode about this because women need to hear the other side of the testosterone replacement therapy story, because it seems to me that when you're out in the world of social media, we're getting a lot of the glamorous things about testosterone for women, and that there's a lot of awareness being brought to the public about it, which is fantastic, and I'm so happy. And I've definitely been somebody that's gone out in my social media platforms and discussed this at length, at how great and how important testosterone is for women. In our fertile years, testosterone can be one of our most abundant hormones, and we can actually produce more testosterone than we do estrogen or progesterone. So it is really important. We just don't make it in the same amounts that a man does. And so because of that, we're just kind of forgotten about in the world of testosterone replacement therapy in mainstream medical system, which, all HRT in mainstream medical it still has a long ways to go. Let's just put it that way. But testosterone is way at that bottom of that list. Now, over the years, so we've had our clinic now for over 5 years, and we've been replacing women's testosterone. And we do a lot of it. Thousands of women have now come through our clinic and have been prescribed testosterone replacement therapy. And they thrive on it. Women do. They absolutely thrive on it. It's so necessary if their testosterone's low to make them feel like themselves again in menopause and perimenopause. It can give them energy. It gives them sometimes their libido back. Not always, but a lot of the time, if the libido disappeared during perimenopause or menopause, then typically we can add testosterone and estrogen back in, and it can revive the libido. It can give mental clarity. It can actually act a little bit like an antidepressant in the body, which I think is super cool. I definitely noticed that with myself, that when I started to replace my testosterone, I had better moods. My mental health was better, which I'll take all of that, all of that I can get. It can help you put muscle on, which is so important for our metabolic health because it really starts to suffer during the loss of our hormones. And so there are so many amazing, amazing things that testosterone replacement therapy can give to a woman or give back to a woman if she's lost them. And so today's conversation is not about all of the good stuff. I want to talk about all of the things that can happen and that we see happening often, not just one or two women out of a bunch of them. It's not a rare handful. Enough women we were seeing in our clinic in the beginning, I would say 80% were getting these, or one, two, if not all of these side effects that we're going to talk about today. Enough that we had to stop and say, okay, what is going on here? Like, why do so many women get these negative side effects when they start testosterone replacement therapy? So me and my staff and the doctors, we went back to the drawing board. We reevaluated how the physicians were prescribing it. We dug into the labs, the genetics, the delivery systems, and of course, the dosing. And what became clear is this: most of these side effects weren't happening because testosterone is bad for these women. They were happening because women were being started at far too high of a dose and using delivery methods that spike levels or not getting the right education around how their body could be metabolizing this testosterone. So in today's episode, I'm going to walk you through the side effects we see the most, what causes them, and most importantly, how you can avoid them so testosterone works for you, not against you. Now I want to just zoom out for a minute and talk about why testosterone behaves the way it does in a woman's body. Because when you understand the physiology, the side effects suddenly make a lot more sense. Women do make testosterone, just not in the giant steady stream that men do. We produce it mostly from our ovaries and adrenal glands. And in healthy premenopausal women, testosterone sits in this gorgeous little physiologic window where it fuels libido, motivation, energy, and muscle mass without tipping over into I am growing chin hairs and my voice is cracking territory. When we replace testosterone, our goal is not to push women anywhere near male levels. We're aiming to restore what a woman would naturally produce in her prime years, just enough to feel like herself again. Which I will say, it doesn't feel as good as the big doses do. When women are put on the big doses, and we'll talk about what that is, they actually tend to feel absolutely amazing. It's a high, it's a steroid high. And they can get a big push in their libido. They get a big push in energy. They feel like they can just conquer the world. And they're like, wow, this was so amazing. I love this. Is this what guys feel like? Jeez. But that, unfortunately, is not natural to the female body. And we start to see almost across the board these horrible side effects eventually pop up. Whether it's a month in, 3 months in, or 6 months in, it's almost inevitable that if she's got those really high levels, that she's going to start seeing these side effects. Now, many of these women, they're being started on doses that overshoot the physiologic window by a mile. They're being given doses that are appropriate for a 180-pound man, not a 135-pound premenopausal woman. And when you overshoot, you start drifting into what's called super physiologic levels. Levels the female body was never designed to handle. We're women. We're not supposed to have that much testosterone. And that's when we see the side effects. So it's physiologic replacement versus super physiologic dosing, which is what we're seeing a lot of. And this is a huge distinction most women are never told about. Physiologic replacement means you're giving the body what it would naturally make. You're restoring, supporting, nudging. This is where women feel stable energy, an improved libido, sometimes clearer thinking, better muscle tone, more motivation. Super physiologic dosing, on the other hand, goes way beyond the female range. And this is where things almost always start to go sideways. Acne, hair loss, facial hair, enlarged clitoris, oily skin, mood irritability or downright rage, water retention, voice changes. Most negative side effects aren't a failure of testosterone, they're a failure of the dose and delivery method. Now, that said, we see women, even on modest physiologic dosing, still can get side effects. And there are a few reasons for this, which I will get into. But first, delivery method matters. You can give the exact same dose of testosterone via 2 different delivery methods and get completely different outcomes. Here's the rundown. One thing I want to clarify, because this gets massively misunderstood in women's hormone care, is the difference between how topical testosterone and injectable testosterone behave in the body. A lot of clinicians still reach for creams first. But here's the truth. Injectable testosterone is often better tolerated and works better than topical cream for women, as long as the injectable dose is conservative. And the reason has everything to do with an enzyme activity in the skin. It's the role of 5-alpha reductase. It's an enzyme that converts testosterone to DHT. Women are often told to fear testosterone because of the side effects like chin hair, acne, and hair loss. But the hormone causing those issues isn't actually testosterone itself. It's dihydrotestosterone, DHT, which is a very strong androgenic hormone. The skin contains extremely high levels of 5-alpha reductase, the enzyme that converts testosterone to DHT. This is especially true in the scalp, the face, the chin, jawline area, the vulva, the clitoris, the chest, and back. So, when a woman applies testosterone to the skin via cream, she's delivering it directly into the tissue that has the highest 5-alpha reductase activity. The result? Topicals tend to convert disproportionately into DHT compared to injectables. This is why many women will get the oily skin, the hair loss, the facial hair, and they get it fast on topical forms. I've seen women where they apply testosterone cream on their body get patches of dark hair just on that spot. So if they're rubbing it on their inner thighs, on their inner arms, they'll get hair growth in that area, which, we do not want that. Injectable testosterone, like testosterone cypionate, in smaller doses than what a man is given, much smaller doses. So a man's typical dose is around 200, 250 milligrams a week. A woman should be 5 to 10 milligrams a week. When you are injecting, it bypasses the skin and is absorbed systemically because it's not hitting the 5-alpha reductase rich skin tissue first. The conversion into DHT is significantly lower. And here's an important nuance. Small, frequent microdoses, so that could be 2 injections a week, maybe an injection every 5 days, even 3 injections a week if you're very sensitive to it can be better. And lower DHT will be happening and more stable levels. Compared to a large bolus injection, so if you did it all at once, it can spike levels really high, and then the side effects are a higher DHT. Because the body has to do something with it. If you've got all of this testosterone suddenly in your body, it's going to push it down these certain enzymatic pathways, and it can start to push down that DHT pathway faster than if you were to microdose and split the dose up into smaller dosing in injectable form. So injectables aren't automatically like give you a clean, free pass on this. Nope. You can still absolutely get side effects. It's just, we see it happening less. We see the conversion to DHT happening less. A good example, many women, they do beautifully on 5 to 10 milligrams per week, and they can split that into 2 or 3 microdoses, but give that same woman 20 or 40 milligrams weekly at once, and boom, she's going to have breakouts and mood swings. And then there's something called aromatase. Aromatase is the enzyme that converts testosterone to estradiol. So testosterone can go to DHT and it can go to estradiol. And where is aromatase found? Fat tissue, ovaries, breast tissue, brain, and bone. And I question the breast tissue because some newer research that's coming out, and I talked about this in a podcast I did in the summer with nurse practitioner Christine Farrell, where they're seeing that testosterone is not converting to estrogen in breast tissue. So when you look it up in the medical books, you'll see that, it can be aromatized into estrogen in the breast tissue, but they're seeing in these studies that it isn't. And they're actually being able to place testosterone pellets inside breast tumors, and it shrinks the breast tumor. I think that this is phenomenal. So testosterone, there's another bonus to testosterone replacement therapy, is that it can be breast protective. And they actually see in research that women with higher levels of testosterone have less breast cancer cases. How crazy is that? So I question that one, but in most cases, yes, the aromatase can mostly be found fat tissue, ovaries, and it is not concentrated in the skin the same way that 5-alpha reductase is. So aromatase isn't the major culprit for DHT related symptoms with topicals. The 5-alpha reductase is. So there's just a little bit of the science of what's going on with our testosterone inside the body. And all of our estrogen, just so you know, the estradiol, all of it in our ovary is made by testosterone through aromatase. So female comes from the male hormone inside the ovaries, which I think is kind of cool. Now, women with higher body fat may mean then that they will aromatize more of their testosterone into estrogen while simultaneously converting a portion into DHT through the skin route. That combination, not great, can lead to water retention, mood changes, breast tenderness, acne, and paradoxically, no increase and a lowered libido for some. So this is why dosing and delivery method matter so much. So topical creams tend to produce higher DHT, leading to more side effects. Injectables, when microdosed, and for many once a week can be just fine, as long as it's not a huge amount, produce more stable levels with less DHT conversion. Not no DHT conversion, but less. Side effects are more often related to the delivery method and dose than testosterone itself. And when it comes to how you inject testosterone, we've also noticed things that are working better than others. And that is intramuscular versus subcutaneous. And we see that subcutaneous could be a little bit better when it comes to the side effects. So IM is intramuscular. So that is a bigger needle, scarier needle, if you ask me, into the thigh, the quad, or the butt, and injected. Sub-Q is when you inject a nice small little diabetic needle that you can't feel, which I much prefer, into your fat. So you kind of squeeze the side of your hips or your butt, and you can inject into fat tissue instead of muscle. And once again, way easier because it's a smaller needle. But they both create an oil depot, that a little oil deposit in the skin or in the muscle, and then it slowly releases the testosterone into the bloodstream. And once the testosterone is circulating, conversion into DHT doesn't happen in the injection site. It happens in tissues like the skin, hair follicles, genitals, and liver, where 5-alpha reductase is actually active. The main difference is how smooth the hormone delivery feels. An IM injection can create slightly higher peaks and lower troughs, while sub-Q tends to produce steadier, more even testosterone levels. So those sharp IM peaks may indirectly nudge DHT higher for a short period, but that's due to the temporary rise in testosterone, not because muscle has more 5-alpha reductase. For most women, sub-Q provides a gentler, more stable experience with fewer side effects and easier self-administration. Okay, now pellets. The delivery method that looks so simple and convenient on the surface, but causes some of the worst side effects in women. Pellets are essentially a time-release implant placed under the skin that dissolves usually over 3 months. Sounds easy, right? The problem is dosing precision. Most pellet formulas were originally designed with men in mind. And when you apply those same calculations to women, you end up with massive overshooting of testosterone levels. I'm talking 3, 5, even 10 times the physiologic range. I have seen it in women's blood work. It's crazy. They'll have testosterone levels of an older man with not a lot of testosterone, but it still goes into the whole male levels. And once the pellets are in, you're stuck with them. There's no way to titrate down, no way to adjust the dose, and absolutely no way to pull back if a woman starts breaking out, shedding her hair, massive water retention, weight gain, voice cracking, or noticing her clitoris enlarging. You simply have to wait it out. To make matters worse, pellets have a slow washout period. Even after the peak passes, elevated levels can linger for months, which means the side effects linger too. This is why we see such a high rate of irreversible or long-lasting symptoms, especially DHT-related issues coming from pellet-based testosterone. It's not that the pellets are inherently evil. It's that women need flexibility, precision, and the ability to course correct quickly. And pellets offer none of that. I always tell women, if you're interested in testosterone pellets, please start with topical or injectable first. Find your dose and see how you react to the testosterone before committing to pellets. They're also the most expensive form of testosterone. The least expensive, injectable testosterone cypionate. Cheaper than cream, cheaper than pellets, cheaper than troches. Don't even get me started on troches. They're not good either because you end up swallowing it, and you don't ever want to swallow your testosterone, just like you don't want to swallow your estrogen. So troches are no good either. Okay, so now that we're clear on best delivery form for the least amount of side effects, and if you can't do the needles, which I know some people can't, it doesn't matter how small it is. They're like, no go, not doing a needle. If you're going to do cream, because that would be my second option, would be cream. Number one, you typically have to go with a higher dose. So what would normally be, let's say, a 5 or 10 milligram dose per week, like injection per week, would probably be about 5 to 10 milligrams of testosterone per day for cream to get the same level and to get optimized on the testosterone. So just keep that in mind too. But you definitely want to go a little bit higher when you're dosing with cream. Obviously, talk to your physician about that. Okay, most common side effects, what they mean and why they happen. So number one, I don't know if this is the most awful. There's too many. They're all pretty awful, and we don't want them. But this one is probably the most reported side effect: hair loss and thinning. And I had this. I had quite a few of these symptoms actually. Hair loss and hair thinning. Even on smaller doses, this tends to happen often. And it's freaking terrifying when it does, because it's just like, it's just suddenly you notice. It's like you're ticking along, doing great, feeling awesome. And then the light catches, like it hits your scalp in just the right way, like whether you're at the hairdresser's or, you've got maybe a ring light at home that you, like I do, with a mirror on it, that's a magnifying mirror. That's where I saw mine, where I was like, wait just a minute, I can see my scalp. I couldn't see it very well before, and suddenly I can see it. And yeah, very terrifying. And testosterone can trigger shedding of the hair or thinning, especially at the very top. So you get, when you see a man, a bald man, look, I'm like talking quietly, like somebody's going to hear me. I don't want to, cut down any balding men out there. By all means, balding men can be just as good looking. But I'm just saying, the balding ring around the top of their head, male pattern balding, that's from DHT. And so women will start to get hair thinning and hair loss in the same place, which is right at the top of their scalp where the part is. But once again, it's not the testosterone that's the villain. It's DHT, the metabolite your body creates via the 5-alpha reductase enzyme. Some women are genetically more sensitive to DHT because of androgen receptor polymorphisms. Essentially, their hair follicles respond more aggressively to even small increases in DHT. This is especially common in women with a history of polycystic ovarian syndrome because they've often spent years with higher androgen exposure and their hair follicles are already primed to react. Here's the part women always find confusing. Your labs can look totally normal and you can still lose hair. Why? Because scalp follicles respond to local DHT production, not just serum levels. A woman can have normal testosterone reading in the bloodstream, but her scalp may be producing DHT at a much higher rate, especially if she's using topical testosterone that increases local DHT conversion. So how do we prevent the hair loss on testosterone? It's going to be the same answer for all of these, but start low, go slow, lower the dose before side effects increase, and start at the lower side effects. Avoid delivery methods that spike the DHT, like pellets or troches, cream for some. Consider switching to the microdose injectables to reduce DHT production. And you can use things like DHT blockers like minoxidil or finasteride or dutasteride. These are all prescription medications, and I'll talk more about those once we get through these. And then check for, obviously, other things that could be causing the hair loss. Sometimes estrogen can actually, the loss of estrogen will cause hair loss. And so if you came onto the HRT scene already with a little bit of sparse hair, it could be from estradiol loss, not necessarily the testosterone or the testosterone replacement. So you just always want to make sure that, okay, is this what's causing it? Could I, be adjusting something else? Thyroid is another one. Low thyroid can also cause hair loss for women in perimenopause and menopause because their thyroid can start to slow down as well. Okay, oily skin and acne. Once again, I had that too. I got the hair loss, I got the acne. I started on 20 milligram injections per week. This was years and years and years ago. And I very quickly, within 2 weeks, I looked like a 13-year-old teenager and had pizza face. I had acne all over my face because testosterone and DHT increase sebum production, the oil production, which is why you suddenly feel like you're going through puberty again. And when levels climb too high or too quickly, the oil glands go into overdrive. Pores get congested and acne shows up fast, especially along the jawline, the chin here, and the cheeks and even the forehead too. So it's pretty much everywhere. Pellets are notorious for creating acne blowouts because they cause a massive surge of testosterone early on. It's not gradual, it's a spike, and the skin will respond instantly. For some women, it's crazy. And once again, there's no stopping it to clear it out. You got to just wait it out for 3 months, looking like you're 13 again. Except, you don't have the body and the flawless skin to go with it, unfortunately, that a 13-year-old would have. Now we're the menopausal woman with some wrinkles and now also acne all over it. Ugh. We just can't have it easy, can we? Okay. Another piece that doesn't get talked about, insulin resistance and stress will also amplify acne. High cortisol and poor blood sugar control increase inflammation and oil production, making androgenic acne worse. So if a woman has metabolic issues, she's going to be even more prone to breaking out on testosterone. So how do we prevent that one? Once again, lower the dose or switch to a smoother delivery method like sub-Q microdosing injections. You can use anti-androgen skincare products that have niacinamide, retinoids, or acelaic acid. I love acelaic acid. It sounds terrible though, but it's not. It's great. It works really, really great for just like red, like little bumps and acne. It does amazing things to the skin. You can also improve blood sugar. So glucose spikes make acne significantly worse, and acne tells us the androgen load is too high for your skin's tolerance, and fixing the dose often fixes the skin. Clitoromegaly. I don't know if I'm saying that right. Clitoromegaly is the medical term for clitoral or labial enlargement. Now, this one obviously can be devastating for women and embarrassing. I've had women reach out to me to say like that this happened to them and how traumatic it was because they weren't able to reverse it. A lot of the time, I would say most of the time, if caught early, like the first signs of enlargement, like to my friend last week, I said that to her. I was like, you need to back off the dose. Like, don't take it for a couple of weeks, let it get out of your system, and then start back on a lowered dose because this is reversible if caught early enough. The odd woman, it won't be reversible. So it's a very serious thing and not something that any woman wants to deal with. A little bit enlargement, sure, I'll take that. That's better orgasms, more sensitivity down there. And if it's happening during sexual pleasure of any kind, and then it goes away after, I would say that that's considered okay and normal, and you're not going to permanently, have an engorged clitoris or labia. And that's definitely something I can say for myself, a little TMI for you, but testosterone replacement therapy has definitely helped with orgasm quality, and it does help with engorgement and blood flow to the vagina for me. So it can do that for you too. And that can be a really good thing. So don't be too afraid of it, but we just want to make sure that it goes back to normal afterwards. Okay, so once again, this is tied to DHT. The vulva and the clitoral tissue have a high density of the androgen receptors. And when DHT rises, those tissues respond quickly. This doesn't happen a lot with the physiologic dosing. Like if your dosing is on the lesser side, like on a smaller scale, we don't see it permanently happening. It just, I rarely have ever, I don't know if I've ever heard of it. It's when women are on the higher levels, the super physiologic dose, or on pellets, unfortunately. And that's when it can permanently happen because you can't get the pellets out. High dose creams can as well. So just keep that in mind and, be careful of it. Start small, titrate up very slowly. But like I said, most of the time it's reversible. But long-term, super physiologic exposure can lead to permanent changes. So keep the low, start low. You don't need to go whammo, even if you have very low levels of testosterone, because you could have no testosterone. You could come in with a total testosterone of 5, 10, something like that, which normally, like healthy, fertile woman, you want to be typically between 25 and 40 is around that range, 40 being on the higher side. 20 is acceptable in some physicians' eyes, which I don't, obviously that's not optimal in my eyes. I would say 25, between 25 and 35 in my world is optimal. Some women do better on a little bit higher. Some women do actually good all the way up to 50, and that's where they feel their best and they don't get side effects. Other women, they get side effects when it's at 25. And so it's really individual, and you have to find out what that is for you. So go low, go slow when you're first starting out. See how your body reacts to the testosterone. If need be, you switch to that microdose. You can split up the dosing. If you're going to do cream, you would start at a very small amount, and you would very slowly titrate up. Okay. Another one is increased body odor. I had this one too. I still do. Whenever I take my injection, for the first few days afterwards, I definitely notice that I have a stronger odor coming from the armpits. Not anywhere else, just the armpits. But it's like, oh, I've got some serious BO going on. So if you've noted, and I've heard other women talk about this, where they're like, I think I have worse, like my BO is really bad since starting testosterone. This is because testosterone and DHT stimulate apocrine sweat glands, especially in the underarms. When the dose is too high, these glands become more active, and the bacterial breakdown of sweat creates a stronger scent. So it's not your hygiene, it's your HRT. And this is often one of the earliest signs that maybe your testosterone dose is too high. But like me, my testosterone is not too high. I just had my levels tested. I'm in perfect free testosterone and total testosterone levels. And I still get the BO for the first couple of days after my injection. So it could also just be that. Just this is how your body's reacting. So once again, lower it. I think obviously wear some good deodorant that doesn't have a bunch of junk in it. You just might have to apply more regularly. Okay, mood changes. Irritability, or what's called the testosterone rage, which I will tell you is super rare. Super rare. And the whole testosterone rage kind of comes from the bodybuilding world, where they were using these insane amounts of testosterone, and they would be rage monsters. And so it kind of got a bad rap for that, because really I don't see it in men, and I don't see it very often in women. I think I've spoken to probably 5 or less women that have told me that it made them super angry and irritable. And so it's just, that's how their body reacted to it. I don't know why or what pathway, like what neurotransmitter this is working on. It could be glutamate. I'm not sure. I'll have to look into that actually. I don't know if there's anything about that, but is it just that it's the masculine hormone and it's going to cause rage? I don't think so, but I'm not too sure. So I think it's going to be acting on one of the neurotransmitter receptors and maybe glutamate, where it's like turning up the glutamate somehow. I'm not sure. So anyways, I'll get back to you on that one. So another, it would just be, it would be telling you that your body does not, it's having an adverse reaction that isn't normal. And this is like progesterone sensitivity. And we see it even occasionally with estrogen, an estrogen sensitivity where it's causing like these adverse kind of opposite reactions that typically is the opposite of what normally happens for women. Like progesterone, most women, they take progesterone, they feel calm, it's anti-anxiety, it's amazing. And then we have this small subset of women that they take progesterone and it gives them anxiety, it makes them depressed. It's the opposite. It's the opposite of the normal reaction to it. And so then it could just be that, okay, testosterone might not be a good fit for you. And that could be genetics. It could be a neurotransmitter problem. I'm not sure, but it could be that you just can't take it. There could be things that could help with the receptor sensitivity and how you're processing it. But we'd have to know what it was doing to address that. Okay. Water retention and puffiness. Yep, I'm going to put my hand up for that one as well. I tell you, had I started with pellets, I would have been a complete disaster. I would have blown up and had acne all over my face because if I take too much testosterone, I get so puffy. My rings feel tight. My face looks all puffy. My bags under my eyes puff out. And I'll actually put pounds of fluid on. And this I discovered was because of the UGT 2B17 genetic SNP that affects testosterone clearance, which I've got. I've got the variant of it. If you have this variant like I do, you don't metabolize testosterone as efficiently, so levels accumulate more easily, leading to fluid retention. So one of the things is to support that if you have this, so if you find that you're getting water retentive, you probably find that you'll get it as well with estrogen if you take too much estrogen, because it's the same, it's glucuronidation. So it affects our glucuronidation, which is one of the pathways in how we break down these hormones. And so you've got this genetic SNP that alters that pathway so that you don't do it very well. And that's what I've got. So I have troubles with glucuronidation. There's methylation, hydroxylation, methylation, sulfation. And so this can be supported through supplements. And one of those supplements, the best one, is calcium D-glucarate. And I'm going to talk about that when I talk about the supplements that you can take. But know that and then as well, really important for people like myself to do small doses, possibly split up the dose. I take mine farther apart. So I'll usually do an injection maybe once every 10 to 14 days rather than once a week. I could split it, but I get tired of doing a lot of needles. And so I just basically, I know what my dose max is, which is 10 milligrams. And if I stick with that and do it every 10 to 14 days, I'm fine. And I don't get water retentive and I don't break out in acne. You can support liver detox pathways, of course, with cruciferous vegetables is great. Minerals, and N-acetylcysteine is one of my favorites, and any sort of liver support can all help with detoxification pathways. Fiber, you need lots of fiber, helps to bind to estrogen specifically and pull it out. And so all of these things can help you metabolize and break down your hormones, your HRT, and so that your body can rid of them in an appropriate manner. Voice deepening. So this is alongside the clitoral enlargement, that it is sometimes irreversible. And this happens when testosterone stays too high for too long. The vocal cords thicken under androgen exposure. And once that structural change happens, it doesn't always revert. So this is, once again, super physiologic exposure. I don't know if I've ever had a woman's voice. I'm sure, don't get me wrong, I'm sure it's happened on low doses. But in most cases, and what I've seen is only with super physiologic exposure to testosterone. Then I see the voice changing happening. So that's cracking, hoarseness, raspiness. And so it can be, if you catch it fast enough and you start to hear a little cracking in your voice, whoa, sign to stop that testosterone. Talk to your physician about it. Let it clear out of the system. And then if you're wanting to go back on it, then you know that you've got to start at a lower dose and maybe a different delivery form. So we not only lose our hair, we'll start losing it on the head, but then we start growing some on our chin. Oh, that's so great. And other places of the body. Like I said, where women apply their testosterone cream, they can actually start to grow black, dark hairs just in one spot that they're putting the cream on. So yeah, this sucks. I had a little bit of this too, like just with some darker, I didn't get a lot of chin hairs, but I definitely noticed even the little fine hairs were darker around my chin area and my jawline. So now I have to always be looking for that. You see the memes on Instagram where the women are scratching their chin and then they feel the long dark hair and they're like, oh my God. Because you don't see it. I mean, our eyesight's going too, right? In midlife. So when you're just looking in a regular mirror, you often don't see them. And I can't tell you how many women that I will be speaking with. I just had this happen recently. She was a good friend of mine, and I know she's on testosterone replacement. And in the lighting that we were in, I could see these long, dark hairs that I'm sure she had not seen on her chin. And I had to tell her discreetly, I'm like, you've got some long chin hairs. And it was like, what? But I found one on my chin recently that I had never noticed, even with my magnifying mirror. And it was a long, thick black hair, not super long, like a quarter inch maybe or something. But I'm like, oh, why? I want people to tell me. It's like if you've got something in your teeth, you want people to tell you because we don't see it. You think I want to be growing a beard and not realize it? No, somebody tell me. And then I also got the little facial blades. They're quite popular right now. People are taking off all their baby fuzz off their hair, off their face, which I'm not going to do that, but I'm not going to start. If you're doing it, great, go ahead. You do what you want. But for me personally, I don't want to do that. And so I do use one of those little facial blades, and I do shave my mustache and just under my bottom lip where I see some of the darker hairs. They're really fine, but they're there. And the mustache, with menopause, I noticed that it just was getting darker, the mustache, and I would pluck and pluck, and it just became so irritating that I'm like, you know what? I'm just going to shave it. So, not something that I care for my husband to see me doing. Like, you're shaving? Oh, I'll come shave with you. Let me just grab my blade and like take off my mustache. Which it sucks because sometimes you forget to shave for a couple of days, and then you'll look in the mirror and you're like, oh my God, I've got the 5 o'clock shadow happening on my upper lip, for heaven's sakes. So there is that option that you can facial blade the dark hairs off. You can get electrolysis, you can pluck, all of those things. But there are some good supplements that we can take that can help block those receptors from the DHT. And it blocks the 5-alpha reductase enzyme and can reduce these side effects. So I will tell you about those in a second. Some women get sleep disturbances. Not often, but it is something that women will notice that they get energy from their testosterone injection or their cream. And so it's usually advised, if you're going to do your injection, you do it in the morning. If you're going to do cream, that you use it in the morning. If you notice that you have a hard time sleeping when you use it at nighttime. With the cream, I was going to say you could do it at nighttime because this will be a slower absorption rate maybe, but just stick with the morning. Okay. Lab work that can get altered. And number one is elevated hematocrit. So most women don't expect this one because it's talked more about in men because men use more testosterone, but women can absolutely develop thickened blood on testosterone. I've seen it, not often, but I have seen it. So an elevated hematocrit, which is on a CBC panel, and that can cause fatigue, headaches, dizziness, or just feeling off. And so you definitely want to monitor that. Working out can help. So lifting weights, reducing your dose, increase injection frequency, and longer time between injections. And then something that you can do if it is elevated, that you can talk to your physician about, is consider therapeutic phlebotomy. And so that's like a very fast way to lower hematocrit, is to go donate blood. Okay, so those are the worst of the worst side effects from your testosterone replacement therapy, all way more common than you think. Definitely can happen, obviously, more to women that have that high 5-alpha reductase activity. You can test that enzyme in urine metabolite tests like the Dutch test, which is great. You can also test DHT levels. We do with we do testosterone-free testosterone and DHT testing in our advanced lab panel, and which you can order off our website. I don't know if you know this, but we have a whole website where you can order all of your own lab tests. We can order anything for you. Mold testing, any serum lab tests. There's even urine testing, food sensitivity testing. We've got it all. So if you can't get your doctor to test, we can. And it's not ridiculous, the pricing on it, which is good. We've been able to get the prices down and we don't mark them up. So, we do, but very minimal compared to what other people do. And so check that out, because sometimes you get these lab reports and you'll be charged, like, from your physician to get all of these markers done, like $1,000, $1,500 I've seen. Our full lab panel is $275. And that's doing a CBC panel, a metabolic panel, all of the freaking hormones, your SHBG, like, it's all the thyroids, like free T3, TSH, free T4, reverse T3, TPO, TGA. And so it can definitely save you a lot of money if you don't have insurance that covers it, or if you have a high deductible that you have to pay, then it's not even worth going through your insurance. But yeah, so making sure that you're testing these things, I think is always great. So monitor your CBC panel. If you do get elevated hematocrit, I think that that's really important. And just in general, get the testing done, see where your levels are at. As far as supplements and medications that can really help, that we use all the time, are number one, the calcium D-glucarate. So it's one of my favorite liver support supplements. It helps with phase 2 detoxification, specifically glucuronidation, which is one of the pathways your body uses to break down excess hormones, including testosterone. If you have a sluggish UGT pathway like me, calcium D-glucarate can help your body clear testosterone more efficiently so you're not building up too much. It's great for water retention caused by the testosterone or the estrogen, HRT. If you have done the genetic testing and you have that genetic variant, then it's something that you would maybe consider having coming in and out of your supplement regime forever if you're going to be on HRT, because you know that pathway needs to be supported because your genetics don't change. And so you can go, okay, I'm somebody that needs calcium D-glucarate. It is going to help with breaking it down. It's more in the gut, but it can be amazing. Now, you do have to be careful. As a menopausal woman, calcium D-glucarate can lower estradiol. Not as much as DIM does, but it can lower it. So you just want to make sure you're maintaining your estrogen levels if you're choosing to take calcium D-glucarate. Okay, saw palmetto. So saw palmetto and other 5-alpha reductase inhibitors. Saw palmetto is the most well-known natural supplement that reduces the conversion of testosterone to DHT. Two other ones that I like, stinging nettle root and reishi mushrooms. They can be really helpful to reduce the acne, hair loss, increase facial hair, and the clitoral enlargement. They're mild. So if you've got a really active 5-alpha reductase enzyme, this may not be strong enough. We always recommend Dr. Amy Horniman's DHT fixer supplement, which has saw palmetto in it. And so you can try that. I'm trying to remember I think my coupon code is just Karen for that. Karen or Karen Martel, and you can get 10% off her DHT fixer. It's also in my shop. So if you go to karenmartel.com under shop, my link and coupon code is in there for the DHT fixer under Karen Recommends. Okay. Topical hair support that it's not prescription. Rogaine, which is a minoxidil. Caffeine-based serums. Serums that contain saw palmetto can be great. Rosemary oil, mild but helpful. The Fully Vital Hair Solutions, which is my all-time favorite hair growth product. That coupon I do remember is KM15. I use that. I mean, it is by far my favorite. I use it every night and it does really help. I do that with some collagen and it can really help with new hair growth. And I see it, because I'll stop taking it and then I'll be like, oh, my hair is looking a little thin, and I'll start using it again. And within a couple of months, I get all this new hair growth. It's really, really a very good product. and he's such a nice guy, the guy that makes it. I've done a couple episodes with him before, but yeah, it's fully vital hair is what it's called. So those ones are awesome. These are non-prescription. Now for prescription medication. So for some women, they just love their testosterone so much. They're like, I do not want to lower the dose, but I am losing my hair and I'm growing a beard or whatever. And in women that have that are genetically super sensitive to hair loss and to that, and they have a really high 5-alpha or just very sensitive to it, then sometimes we got to bring out the big guns. There's finasteride, which would not be my first choice. It's usually dutasteride that we prescribe. Our doctors will prescribe dutasteride for women. Very small doses. Usually, I think it's 5 milligrams a week, some twice a week, but usually it's 5 milligrams once a week tends to be enough. It blocks both type 1 and type 2 5-alpha reductase, can be used topically in low concentrations for women, and it's extremely effective for androgen-related hair loss. Very powerful, but they should be used under supervision. If you are a fertile woman and you are wanting to get pregnant, you absolutely cannot take dutasteride. Another prescription that sometimes women are given for this, we don't, but some doctors do, is spironolactone. And it works as an androgen receptor blocker, but side effects, not fun. It can lower libido. And since many women take testosterone for libido, spironolactone isn't always the first choice. And it doesn't have a great profile. I've never been very impressed with spironolactone. It works, but side effects, no good. Okay, so why some women have side effects and others don't? There's, two women can be on the exact same dose of testosterone using the exact same delivery method, and one feels amazing while the other is dealing with acne and the hair loss and the swollen libido. What is going on? Well, it's not a one-size-fits-all hormone, and how a woman responds will depend on a mix of genetics, metabolism, hormone balance, and even her stress levels. So one, genetics and the UGT-B17, androgen receptors, and CYP pathways. These genes heavily influence how you metabolize testosterone. So the UGT-B17 deletion means slower clearance, higher testosterone accumulation, water retention, side effects. Androgen receptor polymorphisms, higher receptor sensitivity, more DHT impact even at normal levels. CYP enzyme variations, differences in how quickly you convert, break down, and detoxify all your hormones. This is why one woman will get acne on a tiny dose while another can tolerate more without issues. Delivery method. This one's huge. Even with perfect genetics, the wrong delivery method can wreck a woman. So pellets, massive early spikes, highest rate of side effects. Oral troches, rapid peaks, acne, mood changes, breast tenderness. Topicals, higher conversion to DHT because of skin enzymes. Injectable, sub-Q, microdosing, smoothest levels, lowest DHT conversion. Not no, but lower. Dose size and frequency. Women are often dosed like small men. This is where everything unravels. Too high of a dose, even for a week or two, can trigger side effects that snowball quickly, and large, infrequent injections create peaks your body can't handle. Women do best on low doses, microdosing, consistent, stable levels, sub-Q. Microdosing gives the smoothest, most predictable results. SHBG levels, sex hormone binding globulin. If you have low SHBG, you're going to have a harder time. When SHBG is low, free testosterone rises quickly. Even a tiny dose can feel like too much because of the hormone, because more of the hormone is immediately active. Causes of low SHBG: insulin resistance, protein deficiency, stress, hypothyroidism, genetics. Women with low SHBG almost always need microdosing and extremely cautious titration. Metabolic health. Your metabolic landscape determines how your body handles hormones. Insulin resistance increases DHT and amplifies acne and hair growth. Inflammation worsens skin issues and mood swings. High cortisol makes testosterone feel stimulating instead of energizing. When metabolism is off, testosterone magnifies the problem. And estrogen progesterone balance is number 6. No hormone works in isolation. When a woman's estrogen or progesterone is low or unstable, testosterone has nothing to partner with, which increases the chance of negative symptoms. So low progesterone, more irritability, insomnia, anxiety; low estrogen, vaginal dryness, low libido, even with testosterone. High estrogen, on the other hand, water retention, breast tenderness, and mood swings. So that compiled with high testosterone cannot be fun. So make sure you are equally paying attention to all of your hormones. There's too many clinics that are like, here's your testosterone, that's all you need, or here's your testosterone progesterone. And it's like, no, we need that powerful feminine hormone of estradiol to counterbalance the androgenic effects of testosterone. So please keep that in mind. Number 7 is age and menopausal status. So postmenopausal women metabolize hormones differently than perimenopausal women. Lower ovarian output, lower SHBG, and slower liver metabolism mean the dose has to be tailored carefully. So older women generally need an even lower dose to start, and in a slower titration and more frequent monitoring. So if you are well into menopause, and this goes for any hormone replacement therapy that you're starting, you always have to start low and titrate slow, please. You will not have a fun time. And then lastly, underlying conditions. So PCOS, thyroid, adrenals. If you've got any history of this, you're going to be more sensitive to androgen fluctuations, especially those women with PCOS. You're going to be very high converters to DHT. So even if your testosterone's low and you had this history of PCOS, so you had high testosterone through all your fertile years, but now it's down, you're still going to be very sensitive to it, and you're going to still have that high conversion to DHT. So be very careful when you're starting. Low and slow, okay? All right. So side effects don't mean testosterone is bad for women. They mean the dose, delivery method, or hormone environment isn't right. When we honor physiology, go slow, go low, monitor labs, and tailor dosing to the individual, women do incredibly well on testosterone. It's not something to fear. It's not dangerous. It's not too masculine. It's not off limits for women. In fact, for so many of us, it can be one of the most transformative hormones we work with, boosting libido, strength, muscle mass, confidence, energy, breast protection, and overall vitality. But she's a tricky one. And like I said in the very beginning, it's still the wild, wild west. And the reason women get into trouble with testosterone isn't because the hormone's bad, but it's because every woman has her own unique chemistry, her own genetics, her own metabolism, her own hormone landscape. What works beautifully for one woman may be too strong for another. So just because your friend flourished on her testosterone pellets doesn't mean you are going to. Always remember that. Know your genetics. Look at that UGT-B17 status, your 5-alpha reductase levels through Dutch testing, urine metabolite testing. What are your detox pathways that you can get also from Dutch test and your genetics? What is it that you're needing to support? Test your labs regularly, lift weights. Building muscle increases androgen receptors in the muscle tissue, helping your body use testosterone more efficiently. Strong muscles also improve insulin sensitivity, which reduces androgen-related side effects like acne and hair growth. Think carefully about delivery method. Work with a practitioner who actually listens and adjusts. You don't want someone who hands you pellets and disappears for 3 months. You want someone willing to explore different dosing frequencies, different application sites, different delivery methods, and personalize their approach until it fits your chemistry. At the end of the day, testosterone is a powerful tool for women in midlife and beyond. When it's done intelligently, slow, steady, individualized, it can be life-changing. When it's rushed, overdosed, or ignored, that's when we see the not so fun side effects. Now, if you want help with your testosterone replacement therapy, head to KarenMartel.com. We can prescribe testosterone in every state in the US. And we are launching a new HRT program where you're going to be able to get affordable prescribed testosterone therapy and estrogen, progesterone, and whatever else you want. So be sure to get over to our website and be watching for that launch, which will be by 2026. All right, ladies, thanks for tuning in and good luck with your testosterone therapy.